Okay, good afternoon, everyone. Welcome to MAHSA's Faculty of Medicine 102nd CME event. And today we have two speakers, and one is Dr. Mohamed Arsath Shamsudeen from Department of Surgery, Faculty of Medicine, and another one is Dr. Ferry Damarjata Satriono, Department of Paediatric and Faculty of Medicine. So let me introduce today's first speaker, Dr. Mohamed Arsath, and he completed his MBBS and MS Masters in Surgery from India. And he also obtained fellowship in Association of Minimal Access Surgeons of India and also fellowship in Indian Association of Gastrointestinal Endosurgeons. And he is having more than 8 years experience as a surgeon, and he also very interested in some of the research in his area of surgery. And with this, I would like to introduce Dr. Asad to give a talk on surgical management of small bowel perforation. And Dr. Asad, the floor is yours. Thank you.
Yeah, thank you. Um, Now, I'm going to speak about a surgical management of small bowel perforation. Briefly, I'll give you introduction. Perforation of small bowel from variety of causes comprise a majority of emergency surgical admission. It is a common abdominal emergency faced by the general surgeon, and mostly we can. It is very uncommon in the Western world, uh, and also if you see the small bowel, where is the duodenum, ileum, jejunum? In the ileum is the most common site for perforation in small bowel. There may be single or multiple, depends upon the cause. Okay, we can see that it's in picture. Small single perforation and multiple perforation. We can see it depends upon the etiology. We can see that this study was conducted at Narayana Medical College and Hospital, Nellore, Andhra Pradesh, India. This study was isolated 50 patients admitted to the surgery, department of surgery, with a diagnosis of small bowel perforation and who underwent surgery over a period of 2 years. So inclusion criteria only we have taken the patient age more than 12 years and patient only present with small bowel perforation. Most likely some other will be asking questions how a small bowel perforation we know before doing the surgery. Yes, that's why we are I've taken the retrospective studies. That means after surgery only after surgery, that is which is a small bowel perforation only I've taken, because before surgery we don't know whether it is a small bowel or a large bowel, we don't know. Okay, and also so I have taken the patient who underwent surgery. Next one is exclusion criteria, that is patient that is age less than 12 years is not included, and also patient managed conservatively also is not included, and also some most of the patient, for example, donor duodenal ulcer perforation is very common, but this is due to peptic ulcer, that is a quietly I excluded, because a measure of cases will come under it. So I excluded peptic ulcer disease, peptic ulcer perforation ulcer. So I have included only apart from that the duodenum, jejunum, ileum, which apart from peptic ulcer, some other causes which is included. I have taken into account. So data was collected with respect to the age and sex. Detailed clinical history was taken for all these patients with emphasis on all the presenting complaints. Thorough physical examination was done for all the patients. Vital signs were recorded. Presence of gouging or rigidity, rebound tenderness, liver dullness, obliterations was overlooked on all the patients. Absence or decreased bowel cells are also recorded. All the routine blood investigation were also done. Direct abdominal X-ray was done for all the patients to overlook presence of gas at the diaphragm. Because in perforation, definitely we have to go for this abdominal, either a chest abdomen with both the domes of diaphragm, or abdominal X-ray with domes of diaphragm. But main thing is we need a dooms of diaphragm. Then only we can see the gas under the diaphragm. So all the patients were operated upon after adequate resuscitation with a midline laparotomy. Perfusion was managed according to the protocol followed in the hospital. Patient was followed up in the post-operative period to know the post-operative complication, morbidity, and mortality rates. The results in the present study, most common age group was 21 to 30 years, followed by age group of 31 to 40. So majority of in our majority in our part is male, which is 80%. The female is only 20%. We can see that age group. Can you see the cursor? Can you see the cursor?
Yeah, yeah, yeah.
Can you see the arrow mark cursor?
Aroma
No.
not seen. Yeah.
Yes, can you able to see that?
We can see the numbers and all the digits, but not your cursor.
Okay, okay, fine. So in that we can see that 21 to 30 years, we can see that mostly totally 40 percentage was totally 40 percentage of age is under the age group of 21 to 30 years, and we can see more than 50 years is very less. That is only 4 percentage is there. So next one, and the pain abdomen was a presenting symptoms in almost all the cases under study, followed by vomiting or fever, abdominal distension, and also constipation. In the present study, majority of cases had a guarding and rigidity at the presentation. Guarding and rigidity was very important in the perforation case, because guarding and rigidity clinical study itself will say you clearly that it is due to most probably because clinical cases, but that's why while doing your clinical examination, if there is a guarding and rigidity based upon the symptoms, we can conclude, we can suspect that it is mostly due to the perforation, and this chest x-ray will will uh, will prove, will confirm you that it is perforation or not, because some other also is there, like we can see the gas under the diaphragm in some other cases like a Chilaiditi syndrome, where you can see the uh, small bowel is entrapped between liver and the dorsal diaphragm. There we can see the gas also. So but the patient will not have any symptoms at all. So based upon the symptoms only, we can based upon symptoms and physical examination, we can confirm it with the X-ray. Okay. In that ileal perforation was the most common case of small bowel perforation, which account for 80% of cases. In that ileal perforation, in my case, tubercular perforation, which were mostly account for 28% of ileal perforation, followed by typhoid perforation also is there. But typhoid perforation is most common. But in my study, tubercular perforation is the most common. One is iatrogenic perforation. Iatrogenic means like which I will explain you. Iatrogenic perforation was seen in one case of ileal perforation. That is, patient has one that patient had undergone abdominal hysterectomy 15 days abdominal hysterectomy due to the development of abdominal pain, which is not responding to conservative management. But after finishing that abdominal hysterectomy, they entrapped the loops of ileum while suturing. That leads to a perforation of ileum. That is hydrogenic perforation. So we have to do re-laparotomy, and that loop of diaphragm, which was loop of ileum, which was caught in the suture, was we opened, and we did resection anastomosis for the case which I have shown in that here. Okay. Post-operative diagnosis. Then only we can do that. Post-operative is it's mostly it's tuberculosis. Tuberculosis in my case it's 28%, followed by typhoid is 24%, and hydrogenic is only 2%, and non-specific, that is not know why perfection is there, but perfection is there. That is mostly 26%, and general perfection is traumatic is 88%, and the non-specific is 12%. No management how we did now up to that we have seen, but how to do the management, how to do the treatment. Simple closure of perfection was done in 30% of 30 cases, that is 60% of cases, which is followed by resection and anastomosis, which is that is 26%, and 7% of case only we have kept a stoma. Okay. So most common complication in that case was wound infection, which is we can see for 34% in that most of the cases. A re-operation was done in one case. In that after wound, after complication of this after complication of surgery, one case alone we opened and did surgery. Okay, and the enterocutaneous fistula also was managed by re-laparotomy. We came across five deaths in our present study. One death was ileal perforation, where patient developed acute respiratory distress syndrome, which is patient was not affordable for intensive care unit. So, and another one patient was due to exogenous perforation, as the patient developed acute renal failure. Three patients died of septic shock in the postoperative period. So patient was followed for a period of 2 months and the complication was noted. We can see that the complication also in that most common complication is wound infection, where you can see up to first 1 week is a 17%, that is 17%, that is 34%. So after 90 days it has reduced, because after treating the patient, then it was reduced, and it comes only 2.4%. And we can see the no complication rate also is increased, because up to that is after 1 week of a surgery, 56% was there without any complication, but it comes to 96 7.6% after 90 days. Okay. So discussion. My main thought was small bowel perforation causing peritonitis is a frequently encountered surgical emergency in India. Actually, in tropical countries like India, it is commonly affect young men, whereas in Western countries it affects adult with the mean age of 45 to 50 years. In a majority of cases, presentation to the hospital is a late with well-established generalized peritonitis with a feculent or purulent contamination, and so that causes most of the some that increases the most of the morbidity of the patient, and it in turn it leads to mortality as well. So, signs and symptoms are typical, and it is possible to make a clinical diagnosis of peritonitis in all the patients. Perforations of a proximal gastrointestinal tract was 6 times as common as perforation of gastrointestinal tract will be noticed in India, but in Western countries we can see, but in not developed countries, not Western countries, sorry, developed countries like United States, US, Greece, and Japan, where we can see only the perforation most commonly occur in the distal gastrointestinal tract. Okay, but in India, proximal gastrointestinal tract is most common, 6 times most common than distal GIT. Okay, but in the developed countries, only distal GIT perforation is most common in distal GIT than proximal GIT. Okay. So, Khanna et al. From Varanasi studied 204 consecutive cases of the gastrointestinal perforation, and found that over half of the case was due to typhoid. Also, perforation at present was also due to duodenal ulcer, also appendicitis, amoebiasis, and tuberculosis. Other perforation. At the other end of the spectrum, Noon et al. From Texas studied 430 patients of a gastrointestinal perforation and found 210 cases were due to penetrating trauma. 92 were due to appendicitis and 68 are due to peptic ulcer. So this shows importance of trauma in developed countries. Maximum number of cases were in the age group of 20 to 40 years, which account for 75% in our study, and as compared to Ahmed et al. which shows the maximum incidence in the age group of only 50%. So there is a male predominance in the in our study accounts for 44 is to 1. That is a four male, one female, like this it accounts for. And it's compared to Ahmad et al., where we can see 2.5 male and one female, and another Gupta et al. Is 1.7 male and one female. So in our study, most commonly is a male predominance is over more. Okay. In this study, majority of cases has guarding and rigidity and presentation. Rebound tenderness also is present 84%, and absent bowel sounds was seen in 72%, and abdominal distension was seen in 66%, and obliteration of liver tenderness was seen only in 42%, and perectal tenderness was seen only in 12%. Most common complication in our series was wound infection, which accounts for 34%. We come across the 5 deaths in our study. So in Ahmad et al. And Gupta et al., wound infection was most common complication. Mortality in our study is was 10%, and it's compared to Ahmad et al. And Gupta et al. And Alam SM et al., where we can see a 4.4, 5.4, and 6 and 10 each of them. So comparatively in our study is mortality is very more in my study. One death was with ileal perforation, which where the patient has a adult respiratory distress syndrome and not affordable for ICU care. And one patient was in ileal perforation, which where patient developed acute renal failure. Okay, three patients was died due to a septic shock. So delay in seeking medical case, that is medical care, that is a late presentation with a septicemia accounting for adverse outcome of the patient in our study. So our conclusion is in our study, most common site of small bowel perforation is ileum. Resection anastomosis are done or measured of cases, and the most common complication was wound infection, where mortality is 10% because it is due to delay in surgery and also septicemia, also with a high mortality. So this is the uh, which I published a paper, small bowel study of small surgical outcome and of small bowel perforation. In so This study was a study of small bowel perforation. We can see where we can see that typhoid is some another cases. We can see the international journal. I compared my study with the international journal, where we can see 44 cases. In that 44 cases, we can see typhoid is 17 and tuberculosis is only 6. But in my study, out of 40, tuberculosis, I mean, because I've studied 50 cases, so 40 cases ileal perforation and 10 cases general perforation. So I left off general perforation because the international journal study only they have taken ileal perforation. So in this ileum, because I have taken only ileum, I want to show only the ileal perforation, which is quite common. In that we can see 17 cases of ileum in international journal, but in my case it's 14 cases. And we can see tuberculosis is 6, but in my uh, typhoid is 17 in the international journal, but in my case typhoid is 12, but in international journal tuberculosis is only 6, but in my study is 14, that is majority. Okay, so this is this international journal which I have taken from. Next, I have taken from Malaysia. In Malaysia, there will be retrospective cohort study of a non-traumatic jejunum and ileum perforation. Okay, in that I compare with my study also. In that, measured of cases is idiopathic. That is a 29%. In that 42 cases 42 cases was studied, and 12 cases was idiopathic. 7 cases was radiation induced perforation, and vascular induced perforation is five cases, we can see like a mesenteric ischemia or angiodysplasia induced perforation was was 5, and adenocarcinoma induced bigger perforation due to adenocarcinoma was 3, tuberculosis was 2, and gastrointestinal stromal tumor was 2, and miscellaneous is 11. So I compare with mine, but mine I know everyone knows that tuberculosis stands first and followed by typhoid, which is 12, and the non-specific is 13, and the one is heterogenic. This is a retrospective study which I have taken in Malaysia. So another one I have studied fatal gastrointestinal perforation in sudden death cases in 10 years. That is 95 to 96 to 2005 in at the University of Malaysia. University of Malaya. That is during this period, the study of 61 cases of gastrointestinal perforation. In that, male was predominant sex which is accounts for 4 is to 1 female. In that, Chinese was the death was 61 cases actually. So in that 61, Chinese was 27, and followed by Indian, which was 18, and followed by Malay was 5 cases, and other races are 7. That is other races means like one may be like any other like other races, other countries, like 11 cases. So frequency was mostly in 2005, where we have 11 cases. Okay, which in the 10 years, 2005 is the most highest. Okay, average age group also we can see was decreased where 41 to 41 to 50, but most majority is we can see is 31 to 40. Okay, this is the fatal gastrointestinal perforation which I have taken from University of Malaya. In overall conclusion, perforated viscous challenges the surgeon's skill as a technician and his knowledge of pre-operative, intraoperative, and post-operative care of severely ill surgical patient. Majority of patients present with like a sudden onset of abdominal pain. Index of suspicion is essential to diagnose hollow viscous perforation early, as significant mortality and morbidity result from diagnostic delay. Surgery plays an important role in the management of perforation. Evolution and management of gastrointestinal perforation provides some of the most challenging experience for the surgeon with the advent of a new technology. Yes. So, anybody have any doubt?
So thank you so much, Dr. Arsath, for your wonderful talk. So now, any questions from the audience, you can leave your questions in the comment box so that I can ask Dr. Arsath. Okay, if there is no any questions to Dr. Arsath, thank you once again, Dr. Arsath, for your wonderful talk and new insights in your area. It's really interesting to know the new information. So with this, yeah, I think there is one question from uh, Prof. That is, were the diagnosis of TB and typhoid made only at the presentation of perforation or detected before the perforation and had received some conservative treatment?
uh, because in that case, whatever tuberculosis perfection also many our main perfection is only perfection is happen means only we have to do surgery. But after doing surgery, if it by history we know that it is due to tuberculosis, because the patient has history of tuberculosis. But perfection means what we have to cure the perforation, because already the hole is there, perforated part is there. So we need to clear, then we have to give that to TB drugs regimen. So
That
that is the
mean
most uh,
Yeah, that means the patients are already known to have this either typhoid or TB. before
Typhoid,
we identify the perforation.
yes, the patient known, but main thing is our main concern is first we have to uh, uh, well, first we have to cure that patient. Then only we can go into the most probably the detailed history. We know that is TB or tuberculosis, but anyhow, we have to cure. We have to finish it, but then we have to find and we have to confirm with that perfect report, and then we have to take into account that it is a tuberculosis or TB depends upon that. But
Yeah.
mostly tuberculosis, TB before surgery itself we know, but
Mhm.
uh, other cases is there, right? So we can't give issue for other cases. That's why I taken into retrospective studies, because prospective studies, first I started prospective studies only, but it's very difficult for me, because only tuberculosis and TB means okay, but what about the other case also is there, right? That's why because I have seen the regional traumatic perforation and all, I can't take into some other without knowing, but perforation is there also is there, ileal perforation. So that patient and all, what I can do, main thing is I want to cure the patient, cure that perfect part. Then I want to find that etiology. But main thing is it was miscellaneous. It's not showing any specific features actually. Like for this is the reason for having the profession. That's why it is mostly it's miscellaneous.
Yeah.
Uh, yes, I
Yeah.
think
Yeah.
so.
Even as you had shown the data from Malaysia, is more of them are in idiopathic, right?
Yes, most of my in Malaysia, which I studied as mostly is a idiopathic, but mostly I think so. Tubercular perforation is a very less in Malaysia, very less in Malaysia. Yeah, it's only six out of 42.
Okay.
So maybe it's very less in Malaysia tubercular perforation, but in India is more or less is stands equal to the typhoid perforation.
Okay.
Yeah.
Okay. Thank you, Dr. Arshad.
One thing, once again, once again, I want to say that tuberculosis and typhoid, we know that it is a perfection was due to tuberculosis and typhoid, but some other many apart from that, many other decays also is there. So in spite, I will make into prospective to retrospective. Prospective means before study, before surgery itself is prospective. So I made into retrospective. Then only it is easy for me to find out what is the reason for that. Because many reasons I don't know why the perfection is happened. But some we can see that sometime perfection maybe happen due to diverticulitis, but I can't see. David due to the perfection due to David is also is there, but I can't see. I have but in my studies it is not there. It is some in Western countries David is very common, but I think so in India it's not that so common as like in Western countries. So I for the purpose of the to know that only I made into retrospective studies like inflammatory bowel disease also is there. So for that only I made into retrospective studies.
Okay. So thanks, Dr. Arshad, and we will
Do you
move
have
to the
any doubt?
next talk. So if there is any question, if there is no any further question, I think we will go to the next talk of the day. Okay, I think no more. Thank you, Dr. Arshad.
Okay, thank you.
Okay, so we have the next speaker of the day. So we'd like to welcome Dr. Ferry Damarjata Satriono, and he's a pediatric pediatrician in our faculty of medicine, and he completed his bachelor's degree in University of Indonesia, Jakarta, and after that he studied the pediatrician, graduate from Department of Child Health, Faculty of Medicine, University of Indonesia, and is also the part of many membership or society in Indonesia, Paediatric Society Indonesia, Medical Association Indonesia, Medical Council, Malaysian Medical Council, so on, and is also having a couple of publications in the different areas. Shows his interest in the research too, and is having working experience at various levels and different countries around more than 18 years. So with this, I would like to introduce Dr. Ferry Damarjata Satriono to talk on review of physical exercise in type 3 spinal muscular atrophy, benefit or harm. So the floor is yours, Dr. Ferry.
Okay. Okay. Can you hear me?
Yes, 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 Dr. Ferry.
Okay. Okay. Thank you very much, Prof. Venkata, for nice introductions. First of all, I like to would like to thank to the committee for the great opportunity to be talking in this nice uh, event webinars. Okay. Okay. All right. Without any further ado, I would like to present my topics for today's webinars with topics of review of physical exercise in type 3 Kugelberg Welanders in spinal muscular atrophies. Is it benefit or harm? Can you see the slide?
The first slide we could see, Dr.
Okay.
Ferry. Yes, yes, we can see the transition. Yeah.
Okay.
The
All
Spinal
right.
Muscular Atrophy Awareness Month, right?
Yeah. Yes.
Yeah, I can see. Yeah.
So I like to give informations about spinal muscular atrophies. So we have a spinal muscular atrophies awareness month in every August every year. So everyone is invited. Okay, right. So beyond that one, we have supporting peers group as well around the world, like in Indonesia, Australia, Australia, and even Malaysia. We have a supporting group for spinal muscular atrophy. This for your kind information. Okay. Okay, let's start about the spinal muscular atrophies in brief. Okay. Actually, spinal muscular atrophy. So later I will abbreviate this with SMA. So SMA is a neuromuscular disease, which is a degeneration of motor neurons, alpha motor neurons, caused by deletions or mutation of SMN1 gene, which is heredited by autosomal recessive. The prevalence of this case is 1 in every 6,000 to 10,000 newborns, with a carrier state of 5 to 10%, which is reported by With and colleagues. Which the most common places is, if you see in the Europeans, it's the most higher. In US, in the multi-ethnics or multi-races, there is some report, and in Asian we have as well is around 7.5%. Okay, so what is the clinical hallmarks of hypotonia? Of the SMA is hypotonia, muscle atrophies, and muscle weakness. So this is a brief information about spinal muscular atrophies or SMA. So SMA is classified by 4 types. Okay, consists of 0, type 1, type 2, and type 3, and the last type 4. This is the conventionals or the previous classifications based on the clinical manifestations or sign. But nowadays, we classified the patients as a non-sitters, sitters, and walker. So why do we change or little bit change the classifications of the SMA? Because later, these sign and symptoms actually correlate with the SMN2, okay, SMN2 gene, okay, which is represented by the bar diagram below. So this is SMN2 copy numbers. If we see carefully, so in every type, there's a difference. There's a difference numbers of the SMN2. So this is the number represent copies of the SMN. So this, sorry, SMN2. So this SMN2 have correlation with the movements or the what's called the muscles movements of the patients. Okay, more copies meaning better movement. For examples, like in type 1, the most patients will have 3 copies only of SMN2, and it is worse than type 3, which is have 4 copies, 44%, and the what you call the mildest will be 81%, 4 copies of SMN2 in type 3. In type 4 will be more. Uh, so basically, what is the cause of the SMA? Actually, it's a single mutations only in the exon 7 in the chromosome number 5. So we see in the DNA, it's only a changing one single amino acid, which is cytosine, is changing to thymine. Okay, thymine. So in the mRNA, normally in the normal patients or normal populations, exon 7 will be included in the productions of the protein, which the last of the production is Fmn protein, which is very important for the cells metabolisms, including nerve cells. But what happened in the SMA is there's a changing one amino acids in the mRNA, in the pre-mRNA. Then in the process of the mRNA, the cytosine is changing with to the uracils in the exon number 7. Since it's a changing of one single amino acids, then the exon number 7 will be truncated. The exon number 7 will be truncated, and the functions of the protein which produce is not optimals or suboptimals. So that's what we call SMN delta 7. What's the meaning of SMN without exon number 7? But fortunately, the patient with the SMN, especially with the high number copies of the SMN2 genes, the sum around 10 to 20% can produce SMN as well. But of course, the SMN is not the same with the what you call, if you want to say, the normal SMN. It's not the same, but at least we have some similar protein, which is 10 to 20%. Okay. Because of the one singles changings of the mRNA, then the phenotypically very varies, which is heterogeneous, from the life-threatening to the life-altering disease, which means from type 0 to type 4 because of these singles mutations only. But what is make it different is the copies of the SMN2 genes. Okay, so we see the nurtures of the disease. We see the nurtures of the disease. We see that this is the type 1 or the most severe. Okay, this is the type 4, the mildest type of the SMA. Okay, if we see in the earlier life, in the early periods of life, all will share the same developments. But in some area or sometimes or after some period, the type 1 will have degenerations or alterations of the disease. So the disease cause muscle weakness and mobility problems. At the end, in the severe one, the patients will have a risk to have respiratory arrest because of the muscles arrest. This is the type 2. As we know, the type 2 is more SMN gene 2 copies. So clinically will be better than type 1, same as type 3. But interestingly, in type 3, they have opportunity to reach walk, the development walk. So in these patients, we call walker types. Walker types. If we compare with the type 2, they never reach the walking. Okay. So we call it sitters only. Maximum the patients only can sit, cannot walk, and regress. In type 3, it's very interesting. Type 4, almost like normal patient, but little bit weakness. The most interesting one is the type 3, because in type 3, the patient may maintain the ability to walk or maintain ability to have mobilities. In the other hand, if the patients have less SMN2 gene copies, then the patient will fall to have less than walking ability, meaning patients cannot walk independently. Okay, almost like type 2. But what's different is in type 3, the patients can walk before regress. Okay, let's see about type 3 SMA. What is the interesting about type 3 SMA is if we see the Dr. Montes and colleague have studies about the annual rate of, or we call it 6 minutes walk test. So the test is designed to see or to evaluate the endurance of the muscles, the endurance of the powers of the muscles. Okay. So if we see less than 6 years, in every year they reach higher or longer distance. But then after 6 to 10 years, in the population 6 to 10 years, the ability is lesser, even become regress, and more in adolescence. More than 20s age, which is more in the type 4, of course, the regressions or the declinings of the walk to reach meters in the 6 minutes uh, distance test is higher than the teens. Okay, so most of the teens will be number SMA 3. So this is Dr. Montes. That's why in type 3 SMA, which relatively preserve residual strength, it becomes ideal target for exercise studies. And hopefully, by the exercise, we can maintain or we can even increase the powers of the muscles of the patient with the SMA. Okay? Because at the end, our aim is to make the patients independently can walk, or at least we delay the regressions of the disease. So let's talk about the preclinical studies of this patient. Okay. So why the exercise become interesting? Because there's some preclinical studies has done during 2005. So initially, uh, we have preclinical studies about exercise in the uh, mouse, in the transgenic type 2 like mice as a models for the patients with the SMA. This has been done by Gondat in 2005. So Gondat actually trained group of mice with force run in the wheel with increased speed gradually and started by 10 days of age of the mice. So interestingly, the effect on the trained samples or trained mice, the survival time is increased. The muscles powers and the locomotions is increased as well. From the histopathologies examinations, the apoptosis is lesser or no apoptosis increasing compared to untrained mice. And the exon 7 contain SMN transcript is higher compared to the mouse which is not trained. So this lead to the conclusions that the exercise enhance muscle strength. Secondly, the exercise has neuroprotections, which can be seen by the neuronal depth and exon 7 contain SMN on the histopathology examination. So based on this, it's we have evidence that exercise might have benefit for the patients with the SMA. So the others preclinical studies done by Tali in 2016. So this is preclinical studies which using SMA3 like mice. So difference. Uh, the last preclinical study is type 2 SMA like mice. This one is type T SMA like mice. So what they did is they have three populations of the samples. Then the treatment will be different. The treatment number one, first sample is sedentary. Second is low intensity running, and the third one is high intensity swimming. So what important information from this preclinical studies? This is the first studies. This is the first study that compare running and aquatics or swimming. Which one is best? Okay, so they did 10 months, which is 5 times a week, 20 minutes exercise for the mice. So they do evaluation by second month, third month, 6 months, and so on up to 1 year. So the result is apparently in these studies, swimming or aquatic in the mice is better than running only, or what you call it, dry land exercise, what we call it, maybe dry land exercise. So swimming is better, okay, what they find. So the conclusion is the long-term exercise, which is 1 month in total, there's a significant improvement in motor performance in both, okay, in both. Of course, the levels of the improvement will be different, but both compared to the sedentary mice life is different. So secondly, reductions of muscle fatigabilities. Again, motor neuron neuroprotection from these studies, from the histopathology examinations. Then preventions of neuromuscular junctions and muscle phenotype alteration. So both of the preclinical studies shows that exercise might have benefit for the patients of spinal muscular atrophies. So how to apply in the human? Since this both examinations or both clinical studies was on the mice or animal studies. So basically, this one is not so difficult because exercise actually is integrated with our life daily exercise. But the thing is, we don't know which is exercise, how to do exercise, and so on. So we are going to apply the some clinical studies to apply the exercise to the patient with SMA. Is it going to be benefits, safe, or harm for the patient with SMA? Okay. All right. So what kind of exercise is very important as well, because if the movement is irregular, unplanned, and unstructured, it's not counted as an exercise. So by the definitions, exercise is a physical activity which is planned, structured, and repetitive. Okay. What's the purpose of this exercise is conditionings of the any part of the body. So this is the definitions by the medical dictionaries I had from the searching, feeling. So this is the mean of exercise, not just irregular movement, unplanned, unstructured, or unrepetitive movement. Okay, then what kind of exercise? Actually, we have 4 exercise, but I want to emphasize to only 2 exercise. Exercise is muscle strengthen exercise, aerobic exercise. The other 2 exercise is flexibility exercise and balance. Okay, basically the balance and flexibility can be integrated in both of these exercise, which is muscle strengthening or aerobics exercise. What's the difference? Muscle strengthening exercise is a progressive individual. This is definitions by the American College of Sport Medicine. So what is muscle strengthening exercise? It's a progressive individualized program at all major muscle groups, at least one set of 8 to 12 repetitions, and the frequency is 2 to 3 days a week. The aerobic is use large muscle groups, rhythmic, aerobics, and so on. Frequency will be almost every day, 3 to 5 days a week. But the principles difference of these two exercise is in aerobic, actually, we are going to find or we are going to aim for the fitness because it's going to affect the cardiovasculars and oxygenations to the tissues. Okay, so it's for the fitness of the patients, which is muscle strengthening actually for the powers, postures, and ability to stand in one position against gravity. So it's different. So actually both have two interplay that is enhancing each other. So what is our aim for exercise in the SMA? The aim is number one, muscle functions and muscle strength, which is represented from the uh, muscle strengthening exercise and aerobic exercise. So the aim of this exercise is the daily activities. For the daily activities, school activities, work activities, and social activity, which can improve the qualities of life of the patient. Okay. So let's start with the what we call it dry land exercise. Okay, dry land exercise is for the type 3 SMA. The questions is safe or harm. Is it safe or harm? Okay, so this is a study from Madsons and colleagues. Of course, the number is not so many because the case of the SMA is not so many as well. Okay. The intervention is the what you call the cycle ergometric training for 12 weeks, which the result increasing of V2 VO2 max with no muscle damage on the patients. And the studies suggest that this what you call the exercise is safe for the patient for the SMA. Again, in the same years, Lewell have another studies, similar studies, 12 weeks as well, with progressive resistance training. Okay, if we see in the medicine set and colleague, actually the cycles ergometric training is uh, aerobic trainings, aerobic training. So in the level is resistance, which is muscle strengthening training. The result was training session were pain-free in almost all of the populations. Of course, 9 patients only. No studies related adverse events occur. So the remarks is safe. Okay. The other study is Montes and friends. Numbers of sample is 14, which is cycling and this is a combination of aerobic and muscle strengthening. So the result is daily exercise is safe in ambulatory SMA and should be encouraged. So three of the studies suggest that exercise in type 3 SMA is safe. Okay, safe. So what about the exercise impact in type 3 in the Montes? They do some what you call the study as well. Now, if we see carefully, the last studies is a single study, which means there is no control. So starting from Montes and colleague, they have control and treatment, okay, which is 14 samples for type 3B and 3 as a control as a 7, and the exercise is 7 as well, 14 samples. So little bit what you call the balance, but balance. Of course, 14 samples since this is a rare case. So the remark is no deleterious effect on the strength functions and or fatigues observed. So the thing is, if there is no deleterious effect without any improvement, so what is so importance of the uh, exercise in the patient with the SMA? So in the patient with the SMA, actually, even if there's no improvement, we are going to prevent the remaining powers of the patients before it becomes deteriorated. Okay, so Even no deleterious effect, even there's no improvement, is already advantage in terms of patients of SMA. This one almost the same level, the same samples. There's some improvement only, but the trends improve strength and motor function were observed. At the end, will increase the quality of life of the patients and the caregivers as well. This is very important, and I mean, it's a very interesting because it's compared in one individuals. Okay. Three patients is sorry, six patients type 3 SMA. So it's on that six patients, they compare left leg, okay, and other leg, right leg. The result was the increasing in muscle strength, okay, in individuals, 30% in children and 20% in adult. The interesting one is when they compare the trained leg compared with the untrained leg. There's an increasing 17% muscle strength and muscle size compared to that one. The meaning is, even in the singles individuals, if we train the muscles will respond, meaning can give advantage for the patients. Maybe in a different individuals will be different result. That's understandable. But in this patient is single patients, one patient, but the difference quite significant. So let's go to the waters. Let's go to the water. So previously we discussed about exercise on the dry land. Now we are going to discuss about aquatic. So what's the difference? Is there any advantage on aquatic based physical exercise? Of course, the problem with the SMA patient is the gravity. They have problem with the proximal muscles powers, lower limb proximal muscles power. So gravity is become an issue. In the patients in SMA, when they do aquatic based exercise, which is in the water, then the effect of gravity is not significant anymore. They can move freely. Okay? That's the advantage of the aquatic based physical exercise for the SMA patients. Secondly, it improves autonomy and movement because of the less gravity. The patient can move as the patients, quote unquote, like a normal patients in the land, which is patients can move anywhere and can move freely in the water because of the less gravities. And neuroprotective adaptations. So the effects of the aquatic based physical exercise is an aerobic effect as well. So given impact to the patients to become what you call protective adaptations, okay? And enhance quality of life, of course. Another important thing is the safety and the fear reductions. As we know, the patients with the what you call the SMA, patient with the SMA will have problem with the gravities and easily to fall. Then after fall, the patients become injured, which is not happening in the water. Of course, there's a risk to become drowning, but will be minimized because will be observed closely with the caregiver. And there is no risk for fall in the water. So the reductions of the fears for reductions of safety, there is no fear and very safe on the water. Okay, then what about the study? Is there any studies for the aquatic base compared to patients with the land or dry land exercise? If we say that, we could say it's dry land exercise. So this is only a case report in 2010, which is a 3 years old female in aquatic therapies with the case report. 14 weeks, 2 times week with the durations of 45 minutes. What's happened is after they interfere the patient with this exercise, then the patients can walk, can run, jump better than before. So the results suggest that improvements, motors, and gait happening in the patient with deep SMA if they do aquatic exercise. What is the evidence? So if we see pre-interventions, this is the lower limbs proximal muscles. This increments of the powers with the scale is 0 to 5. The increment of the power if compare with the previous on the right side and the left side. If it is increasing of the powers of the patient, okay. Then what about gross motors? Patients can crawling, kneeling, standing, and walking better than previously. Okay, if you see the raw score increase, okay, increase the raw score. Okay, standing, walking as well. Then from this patient, this study as well show that the gauge speed is reducing from 0.49 to 0.7.4, meaning the gauge speed is become slower. Is it good or bad? Is it good because the patient can control the movement, meaning longer will be more stable. The stride is wider. The stride time is shorter. So patients can gain walk better after interfere in the aquatics. Okay. All right. Another aquatic exercise studies is previously by Chunha. This initially with Chunha in 1996. It's a cohort perspective, 20 samples with the aquatic therapies, 1 times a week with the Hellevik method. So Hellevik methods is the methods which designed for the patient with the neuromuscular disease. Okay, and it is planned, structures, and can be evaluated. In the child, 30 minutes, in adult, 45 minutes. The durations of study is 2 years. What they have or what they suggest is muscle strength stabilize in most patients with type 3 patients and improve in some. Is it good? I think it's very good because even it's not improved, meaning we can preserve the remaining powers. But this one, improve in some, okay, but this patient have muscle strength stabilized. So it's a good exercise. So this is uh, the motorial activities accomplished. The patient can stand before 60. Okay. Then rolling increase. So after 20, the scores then increase. So basically they increase the numbers, okay, if we compare. And this is a muscle strength test. The same. The result is the same. The same 12, distals 12. Okay, but better in 8 and 4 patients. The proximal better in 8 patients and 4 patients. And there is no patients become worse. This is the most important one. There's no patients become worse because of the aquatic therapies. So again, therapies on exercise, even on the dry land or on in the water, have benefit for the patients with SMA, especially in type 3 SMA. So we come to the conclusion. Number one, exercise has no significant harm effect for patients with SMA. Exercise may improve mobilities, but the statistically inconclusive because the numbers and the method is not uniform. Exercise demonstrates clinically improvement in functions and muscle strength. So there's still many opportunity may be explored for research in exercise in SMA, especially SMA number 3. So this is our conclusion for today's. Thank you very much for your attentions. We're going to give back the session to Dr. Venkata Suresh.
Thank you, Dr. Ferry. It's a wonderful presentation on SMA and the role of exercise in SMA. Yeah, before anything, so there is one question from Prof. Arafin. Actually, what you mentioned, everything about the type 3 SMA, right, doctor? Hello, hello.
Yes,
Can you
sorry,
hear?
yeah. Yes,
Is what you were mentioning about type 3 and the role of exercise, right?
yes,
So, Prof. Vanarafin was asking the transgenic type 2 SMA in mice improves with exercise. So, the same thing, type 2 SMA in human can improve with exercise. That's what the question.
yes, yes. Can improve as well. This, if we see
Type
from
2.
the some of the aquatic exercise, there's some studies that mentions in type 2 SMA, the patients gain the wait, gain the this one, okay, gain the improvement. So this is the type 9 samples consists of type 2 mixing type, which is type 2 and type 3 SMA. So both improve.
Great. So the type 2, I think when it is type 2 and when you are talking about type 4, which is almost normal, right, doctor? I think
Yes.
there must be a study even on type 4 to become improving further to become more normal. I think there must be some studies, right?
Yeah. But actually in a type 4 is almost like normal patients. Almost like normal patient, which is the deteriorations of the muscles is not significant for the quality of life of the patients. So people now try to focus on the type 3 because in type 3 the risk of deteriorations of the loss of the motor powers or the walking ability can be deteriorate, uh, not like in type 4. Okay. If we see in the journeys of the disease of the patients, so like in these patients we see in type 4 they never lost. Can you see the slide?
Yeah, yeah, I can see.
Hello? Yeah. Okay. So in type 4, this is the border that the patients can walk. So
Yeah.
in type 4, the patients never lost the
Yes, yes.
mobility functions and the power. So it's not significantly what you call the clinical loss, or the patients the same like normal patient but less powers only. But
Yeah.
in type 3, there is a two possibility. Either the patient is going to be lost the powers of the muscle, which lost ability to walk, or
Yeah.
the patients can maintain the walking abilities. So this is the most interesting and important area that the what you call the studies is interesting focus to this type. If the patient got alterations, then let's do the intervention so the patients still have ability to walk or maintain the muscle powers. So
Yeah.
that's why in the studies is very few studies of type 4 because they rarely lost the powers of muscles or lost the ability to have good mobilities. So now type 4 is the focus of the studies in most of the SMA.
Okay. Doctor, one more question from Dr. Veena Joshi. Um, how do you quantify the improvement of muscle strength?
Okay, very interesting question. Thank you very much, Dr. Fina. So how do we quantify improvement muscle strength? Actually, there is two ways to uh, assess or evaluate the muscle strength of the patients. Number one, we use tools, what we call it, Hammersmith's motor functions scale. So in Hammersmith motor function scale, actually is designed for the children or pediatric, which there's a some scale from rolling, sitting, standing, and walking. And each of the category, they give a scale from 0, 1, and 2, which is 0 is cannot do at all. If the score is 1, then the patients can do but must be helped. And score number 2 is patients can do by themselves. So we can use a score numbers from the what we call it Hammersmith Hammersmith Motor Function Scale. So now people is revising that scale. Initially, the Hammersmith is 36 scale of the point, but now we call it, now there is a Hammersmith Motor Function Scale extended or expand, which is only 20 scale only. So the patients or the evaluators can do more simple compared to the initially here Hammersmith Motor Function Scale. So that's on number, which is a little bit subjective. But for the motor functions, actually we are going to assess the motors or the strengths of the muscles with the sum tool, what we call it dynameters. Dynameters is like a tension meters. Then it's going to be evaluated by the unit of Newton. It's like you're doing the isotonics or when you hold bubbles like that. And uh, we can measure the powers of bicep muscles in newtons. So there's attentions, what we call it dynameter. So it's just more subjective. Most studies are doing use the dynameters. So that's more objective for the muscle strength. For the fitness, for the fitness, usually we are going to use the VO2 max. So VO2 max is as an indicator for the fitness or consumptions of the oxygen for the muscle. But for the improvement of muscle strength, we are going to use a tools what we call it dynameters, and dynameters everywhere. We can find it in some online shop as well. So it's not very difficult to find that meters.
Okay, thank you, Doctor, for the answering the question from Dr. Veena. Doctor, I have one more question. This SMN1 and SMN2, which is one is mutated and which leads to the truncated protein. So that it, the 10% is still SMN1. That mean is a allele of it or how it is, Doctor?
Yeah, this is
Allele.
what we call it what do you call it?
Paralog.
Paralog. Yeah, it's paralog. So it's not similar or identical, but as one of the amino acids, which thymine is become uracils in SMN2 in mRNA, which is in SMN1 is cytosines. So the length, in terms of length, is the same length, but in terms of the functions, of course, will not the same functions. So it's only 10%, and the functions will be suboptimals compared to the SMN1. Okay? But nowadays there is a medications. This Spinraza, Zolgensma, and Risdiplam that can increase the numbers of the SMN2 with the normal length of the SMN, which is not truncated. But somehow, up till today, the price is still sky high, so it's not affordable. Since not affordable, millions dollars have to spend. Then for the maybe for the developing countries, the exercise is still the best choice, unless it's the medications become affordable and available in every countries for all patients with SMA.
And also there is a possibility for research on the gene therapy with the normal sequence, right, Doctor?
Yeah, there's already done around about 3 to 4 years. The Spinraza, the nusinersen, the medication is a gene therapy actually, and it's what we call it. So basically, there is a two medications type in SMA. Number one, the medications. I will show you the slide. Okay, wait. Okay, so basically we have two type of medication. Number one is SMN dependent strategies, which is the patient must have SMN2 copies at least. Okay,
Yeah.
at least. So more copies will be better. So what we call it SMN dependent treatment or SMN dependent strategies. So compare with the SM, and the second one is SMN independent, meaning whatever numbers of the copies of SMN is, there's no point to have that copies because the medication will work not in the gene, but work in the other organelles of the cells. For example, like olexosib is working on the mitochondria of the cells, of the neuron cells, or what we call the redemptive new medication is muscles, actin myosins, and the other is like salbutamol, valproic acid, what you call the GABA, gabapentine, but the result so far is unsatisfactory, less satisfactory than the SMN dependent strategies. So we have two actually gene therapy. Number one is nusinersen. This is the first generations, but the thing is nusinersen must be given frequently and with some intervals, and the deliveries type of the nusinersen is not quote unquote is not convenient because it must be given by intrathecally. So it's not comfort. So they use antisense of the exon 7 and they come to the nerve cells from the CSF and correcting the protein. But the disadvantage of nusinersen is you have to give patients frequent. The second one is omnacinogen abipapovax. This is this is a truly gene therapies with the gene, what do you call the genetic engineering, full genetic engineering that the patients will be given medications made in vitro, which is they made artificials exon 7, artificial gene SMN, then inserted by the viral to the patients, and only one singles therapies only one time. That's the advantage of omnacimnogen abipapovax. In the brain name is Zolgensma. If you given only one time, and the most important and the safe one is the gene itself is not integrated with the host. So the host will have two genes like hemophilia. So both will be working. So it's a
It is having
journey or
truncated as well as normal.
yeah, normal. This is a nutter. This is not change the nutters of the disease or modified the ways of the disease. The natures of the disease will be changed because of these gene therapies. The last one is the small, what we call this is the omnacimnogens. So by this time, when I have this slide, they haven't mentioned about Evrysdi or the brand name is risdiplam. Risdiplam is a small molecules, the small molecules to correct or to maintain the exon 7 not get truncated. So far, there's three potentials medications, and it's already have clinical trials and approved by the FDAs. The last one is Evrysdi, is about 1 or 2 years ago. But the first one is nusinersen, which is for around during COVID period, 2019, if I'm not mistaken. So this is the first generations, and Zolgensma and Evrysdi. But the thing is the same. The problem is uh, the cost of the treatment is still very expensive, unaffordable. I think cannot be afford for now. For now,
Okay, thank you, Dr. Ferry. I think hopefully very soon the affordability and the cost of this genetically engineered gene therapy should be low, as well as combined with the exercise therapy, both could help this SMA.
yeah. Hopefully, because there's what we call it the SMA warriors. They call the SM is the warriors, and I think it's truly warriors. The SMA. So the warriors are waiting outside for I think the pharmacies, the one who stakeholders of these medications maybe can reduce the price and so on. And hopefully there's a new medications are coming. Since this is genetic engineering, the blessing in disguise of the COVID-19 is the revolutions of the AI, artificial intelligence, and deep learning, machine learning, and it's revolutionized the genetic engineering field as well. So hopefully not so long the drug will come and affordable. Hopefully, because the warriors out there is waiting. I think
So thank
that's
you, Dr. Ferry. I think a lot of appreciation messages for you from Dr. Jamaluddin, Dr. Veena, Dr. Tegu, and so on. So thank you for your informative talk once again. Thanks
thank
for
you. Thank you
other.
very much. Thank you.
Thanks all for joining our CME event. So let us meet again into 103rd CME event. Until then, bye. Thank you. Take care.
Thank you. Thank you very much.